Hello everyone, welcome to our channel. Let's discuss antiphospholipid syndrome. What is antiphospholipid syndrome? Antiphospholipid syndrome is an acquired thrombophilia which results in recurrent arterial and venous thrombus formation. So let's see a few examples of it. So consider this as the liver. This is the leg, and this is the brain, and here is the heart. So So if there is a thrombus formation either in the hepatic veins, so this is nothing but blood carrying syndrome. And if there is a thrombus formation within the deep veins of the legs, so this is nothing but DVT. And if there is a thrombus formation within the major arteries of the brain, which results in stroke, that is the medial cerebral artery, which is a branch of ICA, internal carotid artery, which results in stroke. And if there is a thrombus formation within the major vessel, major coronary artery, that is the left anterior descending artery resulting in anterolateral wall MI, that is ACS. So these are the examples of recurrent thrombus formation. First, a patient might present with a DVT, and then he might present with a stroke, or the patient might present with an MI. So these are the examples of venous thrombus formation, and these are the examples of arterial thrombus formation. So how do you define antiphospholipid syndrome? Antiphospholipid syndrome is an acquired thrombophilia which is autoantibody mediated, which results in recurrent arterial and venous thrombosis and/or pregnancy morbidity. That is, the females present with recurrent abortions. So let's quickly write it down. So this is an acquired thrombophilia which is autoantibody mediated, resulting in recurrent arterial and venous thrombosis and/or pregnancy morbidity. So just like any other autoimmune disease, this also affects females primarily, resulting in recurrent abortions. And why do these abortions occur? We'll come to that. And again, this is of two types. So antiphospholipid syndrome is divided into two types, that is either primary or secondary. Primary is when antiphospholipid syndrome occurs solely, and it is referred to as secondary antiphospholipid syndrome when it occurs in association with other diseases like SMA. Now there's another entity called CAPS. So what is CAPS? CAPS is catastrophic antiphospholipid syndrome. This is a life-threatening condition where there is rapidly progressive thromboembolic disease involving equal to more than three organs simultaneously. That is, in less than a week, thrombus forms in three different organs in a person. So let's quickly write it down. This is a life-threatening condition which rapidly involves, which is a rapidly progressive thromboembolic disease involving equal to three or more than three organs simultaneously. So, what are the three autoantibodies which are associated with antiphospholipid syndrome? First is anti-cardiolipin antibody. Second is anti-beta 2 glycoprotein 1. Third is lupus anticoagulant. So, how do you diagnose the presence of these autoantibodies within a patient's body? The first two autoantibodies can be detected by means of ELISA, while the presence of a third autoantibody, that is the lupus anticoagulant, this is detected indirectly by means of elevated APTT or abnormal kaolin clotting time or abnormal DRVVT, that is dilute Russell Viper Venom test. It is abnormal and this is abnormal. So there's a catch here. In a patient with prothrombotic tendency, that is a repeated thrombus formation, the APTT should be low, in fact. But why is the APTT increased here? This is due to antibodies blocking the phospholipid action. So there is another mechanism for it. We don't need to know it. So let's just remember that there are three autoantibodies. Let's come to another section. So in syphilis, can you tell me the non-specific and specific tests to diagnose syphilis? Just think over. Okay. So in syphilis, we have two kinds of tests which are non-specific and here specific, which are diagnostic of syphilis. So non-specific, why are these called non-specific tests? Because these may be positive in another conditions also. For example, VDRL and RPR. What are the specific tests? Specific test is treponemal pallidum hemagglutination assay and fluorescent treponemal antigen absorption test. Okay, so these tests are diagnostic of syphilis, that is a specific test, but non-specific tests are non-specific because they are not diagnostic, because they may be positive in other conditions. For example, in antiphospholipid patients, they test positive for VDRL. That is, they have a false positive reaction for VDRL. Now let's come to the pathogenesis of our condition. What happens here is when there is a triggering factor like infection or oxidative stress or a surgery or a trauma, this results in apoptosis of the endothelial lining of the vessel. So this is the endothelial lining of a vessel. when there is a infection or oxidative stress or a surgery or a trauma, these result in apoptosis of endothelial cells, which results to exposure of underlying phospholipids to the blood circulation. So these are the phospholipids which remain here. So when these phospholipids are exposed, these are released into the circulation. And when these bind to serum proteins, result in the formation of new antigens. And to these new antigens, autoantibodies are formed, which results in initiation of our intravascular coagulation, which results in recurrent thrombus formation. So let's quickly revise it again. So when there is an infection or oxidative stress or a surgery or a trauma, which results in apoptosis of the endothelial cells, resulting in exposure of underlying phospholipids. And when these bind with serum proteins, result in the formation of new antigens. So these neoantigens, against these neoantigens, autoantibodies are formed, which results in initiation of the intravascular coagulation, which results in recurrent thrombus formation. So now let's quickly discuss what are the clinical features. Clinical features broadly include the organs involved in the thrombus formation. For example, the same thing comes again: venous thrombosis, arterial thrombosis. So give me the examples of venous thrombosis. Can you think of, as discussed above? First one is DVT, involving the legs, and Budd-Chiari involving the liver. That is the hepatic veins. And if it involves the lung, that is the pulmonary veins, results in pulmonary embolism. If it involves the brain, that is the cerebral veins, results in cerebral venous sinus thrombosis. And if it involves the eyes, results in retinal vein thrombosis, resulting in sudden loss of vision. So the clinical presentation varies depending upon the organ involved. If the legs are involved due to the deep vein thrombus formation, the patient may present with sudden onset of unilateral leg swelling associated with pain and tenderness. If it is a Budd-Chiari syndrome, if the hepatic veins are involved, the patient may complain of severe abdominal pain with abdominal distension, ascites and all. And if the pulmonary veins are involved, the patient may complain of sudden onset of severe breathlessness, And if the brain's cerebral venous sinus thrombosis are involved, the patient may complain of sudden onset of severe headache associated with raised ICT, raised intracranial tension symptoms. And if the eyes are involved, the patient may complain of sudden onset of vision loss. Now coming to arterial thrombosis, again, if brain is involved, it may result in CVA, that is stroke. If heart is involved, it may result in ACS, that is MI. And if legs are involved, arteries of legs are involved, it may result in ischemic ulcers on legs. It may also result in gangrene. And if the bones of the legs are involved, for example, femoral head, it may result in avascular necrosis. If renal artery is involved, may result in renal artery stenosis. And if infarcts may also occur due to the thrombus formation in various organs, for example, spleen, adrenals, and pancreas. There are other clinical manifestations. For example, if the veins are of skin are involved, patient may present with livedo reticularis. If small uh, platelet fibrin thrombi vegetations are formed on the valves of the heart, which are seen on 2D echo, it may result in formation of Libman sac endocarditis. That is small platelet fibrin thrombi vegetations visualized on 2D echo, that is the Libman sac endocarditis. And if the autoantibodies are formed against the RBC, may result in autoimmune hemolytic anemia, and if these are formed against the platelets, may result in thrombocytopenia. The patient may present with fatigue, purpura, example. And why does the recurrent abortions occur in females? Well, the answer to this is due to the infarctions of placenta. For example, let's consider that this is the uterus and here lies the placenta, and small thrombi are found here and there, resulting in death of the placental tissue, resulting in recurrent abortions. So here is a picture of livedo reticularis in a person with antiphospholipid syndrome. As I said, this is due to the thrombus formation in the small venules of the skin. Now let's go to the classification system of antiphospholipid syndrome. It is referred to as revised Sapporo classification. Revised Sapporo classification. Under this classification, there are two criteria. One is clinical criteria. Second is lab criteria. So under the clinical criteria, there are two subheadings. One is vascular thrombosis, that is either arterial or venous. And the second thing is pregnancy morbidity. And under the lab criteria, all the three autoantibodies come into play. That is the lupus anticoagulant, anti-cardiolipin antibody, and anti-beta 2 glycoprotein 1. So, to diagnose a patient with antiphospholipid syndrome, the patient must be having one at least. The patient must have at least one clinical criteria plus one lab criteria. That is, the patient might present either with the vascular thrombosis plus a lupus anticoagulant, or the patient might present with a pregnancy morbidity with an anti-cardiolipin antibody. But he or she must have one lab criteria and one clinical criteria. And there's another catch here. The autoantibody which is tested, this must be tested again at least 12 weeks apart, and that should be positive. That is, autoantibody tested positive must be tested repeated 12 weeks apart at least, and must again test positive. Okay, so this is the revised Sapporo classification. So let's have a look at the table again. So this is the revised Sapporo classification criteria for antiphospholipid syndrome, as I said. So here is the clinical criteria, here is the laboratory criteria, and under the clinical criteria, here we have the vascular thrombosis, suggesting one or more clinical episodes of either arterial or venous or small vessel thrombosis in any tissue or organ. And in pregnancy morbidity, we have again three subheadings up under this. Depending upon the week of gestation, you can just give it a reading. And under the laboratory criteria, as I said, we have three autoantibodies, and these must be tested at least 12 weeks apart again. At least 12 weeks apart. Right? Now let's go to the differential diagnosis. So what are the DDs of antiphospholipid syndrome? So any procoagulant or any hypercoagulable state is a differential diagnosis for antiphospholipid syndrome. For example, hyperhomocystinemia. For example, prothrombin G2210A mutation. For example, protein C or S deficiency or antithrombin deficiency. Remember that this loss also occurs in loss in urine occurs in nephrotic syndrome. Even nephrotic syndrome is a procoagulant state. Factor V leading mutation. Polycythemia vera. And myeloproliferative conditions. So what is the treatment for antiphospholipid syndrome? Treatment is warfarin, and this must be given lifelong. And we have to maintain a INR between 2.5 to 3.5. right? Plus or minus aspirin can be given to these patients. So this is the treatment recommendations for persons positive for antiphospholipid antibody. So let's quickly give it a reading. If the patient is asymptomatic, we don't need to give any treatment. And if this is an arterial or a venous thrombosis, we need to give warfarin indefinitely. And we have to maintain an INR more than 2.5. If the patient has a tendency of recurrent thrombosis, the warfarin should be given and INR must be maintained 3 to 4 with a low dose aspirin. And depending upon the pregnancy, gestation, treatment varies. And in this pregnancy, we can't give warfarin. Is contraindicated. Why? Because it is teratogenic. So only we can administer heparin plus or minus aspirin, especially in pregnant cases. Right? Yes. Now coming to valve nodules or deformity, that is the patient with Liebman Sachs. No known effective treatment and full anticoagulation if embolic and or intracardiac thrombi demonstrated. That is nothing but again anticoagulation should be given. And with the patient have a thrombocytopenia with more than 50,000, no treatment. If less than 50,000 is there, the patient may be given steroids, that is the prednisolone plus or minus IVIG. And if the patient is having a catastrophic antiphospholipid syndrome, that is involvement of more than or equal to 3 organs within a week, anticoagulation must be given plus steroids plus IVIG or plasma exchange. So the criteria for classification of catastrophic antiphospholipid syndrome is involvement of more than or equal to 3 organs. So let's give it a reading. Evidence of involvement of 3 or more organs, as I said, systems or tissues. So this is the first point. And second is within development of these manifestations simultaneously or less than 1 week. Less than 1 week. Third point is confirmation by histopathology of small vessel occlusion in at least one organ or tissue. That is confirmation by histopathology. For example, you can take a skin biopsy demonstrating thrombus in venules of skin, which is the fourth point, lab confirmation of the presence of autoantibody. Fourth point is lab confirmation of autoantibody. So definite catastrophic APS is when all the 4 criteria meet. That is, all the 4 criteria should meet to label a person as catastrophic antiphospholipid syndrome. And what is the treatment for catastrophic antiphospholipid syndrome? As we discussed earlier, this is anticoagulation plus steroids plus IVIG or plasma exchange. Now let's revise it again. The antiphospholipid syndrome. So antiphospholipid syndrome is a condition that is an acquired thrombophilia which is autoantibody mediated, characterized by recurrent arterial and venous thrombus formation and or pregnancy morbidity. So this condition may involve either the veins or the arteries, that is the Budd-Chiari, DVT are examples of venous thrombosis, and stroke and MI are the examples of arterial thrombosis. And this involves females primarily resulting in recurrent abortions. This is of two types, that is the primary and secondary. Primary is when it occurs solely, and secondary when it occurs in association with other autoimmune diseases, for example, SID. There's another entity called catastrophic antiphospholipid syndrome, which is a life-threatening condition, which is a rapidly progressive thromboembolic disease involving equal to or more than three organs simultaneously. Three autoantibodies are involved in antiphospholipid syndrome, that is the anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, and a lupus anticoagulant. These patients have a false positive VDRL. Pathogenesis is when a person is exposed to infection or oxidative stress or surgery or trauma. It results in apoptosis of the endothelial cells, which results in exposure of the phospholipids, which again bind to the serum proteins, resulting in the formation of neoantigens. And against these neoantigens, autoantibodies are formed, which results in initiation of the intravascular coagulation, which results in recurrent thrombus formation. So the clinical features depend upon the uh, type of organ or tissue involved in either venous or arterial thrombosis. And the patient also presents with a special entity called livedo reticularis and Lichtmann-Sachs endocarditis demonstrated on a 2D echo. The patient might also present with autoimmune hemolytic anemia or thrombocytopenia. And the recurrent abortions occur due to the infarctions of placenta. Now, here is the revised Sapporo classification. So, to diagnose a patient with antiphospholipid syndrome, we must have at least one clinical criteria plus one lab criteria, and the autoantibody should be tested again at least 12 weeks apart to diagnose him as antiphospholipid syndrome. Here is again the table. Here are a few DDs, which are again all the hypercoagulable states, and the patient must be treated with warfarin lifelong to maintain an INR between 2.5 to 3.5 and plus or minus aspirin indefinitely. And in pregnant women, heparin is contraindicated. They must be treated with warfarin is contraindicated. Heparin must be administered plus or minus aspirin. And CAPS, that is the catastrophic antiphospholipid syndrome. There are four criteria under this. First criteria is involvement of equal to three or more than three organs simultaneously or less than a week, which is confirmed by histopathology, plus lab confirmation of autoantibodies. The treatment is anticoagulation plus steroids plus IVIG or plasma exchange. This ends our video.